The Harvest Technologies Bone Marrow Aspiration Concentration System, also called BMAC, has been designed to automate the steps for the concentration of stem cells and proteins from autologous bone marrow aspirate. The following video will provide the viewer with the instructions and protocol to utilize the Harvest SmartPrep centrifuge system and the associated sterile disposable bone marrow aspirate concentration kit called BMAC. The instructions shown in this video will help the user to become more familiar with using the Harvest BMAC 30 ml and 60 ml kits for the following. First, the handling and preparation of the sterile disposable components used within the OR sterile field. Second, the aspiration of a sufficient volume of bone marrow and the suggested technique to help assure a viable bone marrow aspirate is harvested. Third, the proper handling of the sterile components used for the centrifugation and processing of the bone marrow aspirate to produce a bone marrow concentrate or BMAC. And fourth, the resuspension and recovery of BMAC with guidance for adjusting BMAC final volumes. The BMAC Procedure Pack consists of multiple single-use trays for the efficient and rapid preparation of bone marrow aspirate concentrate. First, let's identify the components in the BMAC 60 ml bottom tray. The BMAC bottom tray contains the following components: a bone marrow aspiration needle with a sharp and blunt stylet, a specially designed bone marrow aspirate filter bag for the pooling of the bone marrow as it's harvested, a blunt fill needle to cap the 60 ml bone marrow aspirate syringe, and a 30 ml ACDA vial. Next, let's identify the components in the BMAC Sterile Custom Pack. The Custom Pack contains the following components: two 30 ml VAC-lock bone marrow aspiration syringes, a 60 ml syringe used to withdraw the pooled marrow from the filter bag, 3 disposable medicine cups for the heparin anticoagulant solution, ACDA, and local anesthetic used in the collection procedure. There's also betadine solution, a fenestrated drape, a skin marker, a scalpel, a spinal needle, and assorted supplies. Now let's take a closer look at the aspiration needle. Each needle assembly consists of an 11-gauge 10-centimeter long trocar needle and sharp stylet and accessory blunt stylet attached to a handle. A closer look at the needle tip shows the stylet extending beyond the distal hole of the needle trocar and moving proximally 2 centimeters shows the 5 side holes of the needle trocar. Once into the marrow space, the sharp stylet is replaced by the blunt stylet in order to safely advance the trocar within the marrow space and reduce the risk of inadvertently penetrating the medial or lateral wall of the iliac wing. The 5 side holes allow more efficient aspiration of marrow, while reducing the risk of damaging the aspirated stem cells. In the next few frames, we'll be looking closer at the kit components as we prepare these components for use in the bone marrow harvesting procedure. First, open the BMAC custom pack. Next, remove the components from the bottom tray and place them on the sterile field. These items include a bone marrow aspirate filter bag, an aspiration needle and blunt stylet, and an 18-gauge blunt fill needle for the 60 milliliter transfer syringe. Begin by closing the white slide clamp between the filter and the marrow bag. Using the 10 milliliter syringe, transfer the ACDA solution into a disposable sterile cup. Remove the red cap from the in port and place 4 milliliters of ACDA into the bone marrow aspirate filter bag for every 60 milliliters bone marrow to be collected. Ensure that ACDA coats the entire inside surface of the bone marrow aspirate filter bag. Now that all the sterile disposable components have been assembled, the next step is to rinse or coat all marrow contacting components and surfaces with heparinized saline. The recommended concentration of heparin used for harvesting bone marrow is 2,000 heparin units per milliliter of saline. 2,000 units heparin per milliliter is prepared by drawing up 8 milliliters of heparin solution, 5,000 units per milliliter in 1 milliliter vials, into a 30 milliliter syringe, followed by drawing up 12 milliliters of normal saline for a total volume of 20 milliliters of heparin solution at a concentration of 2,000 units per milliliter. This heparin concentration has been shown to be an effective anticoagulant for this procedure. Transfer the 20 milliliters of heparin solution into a disposable cup located in the sterile field. The first steps in the preparation for harvesting is to rinse all the aspiration syringes with the heparinized saline as shown. These steps will ensure that all marrow contacting surfaces of the syringes have been rinsed and coated with heparin. This is an important step that will reduce or prevent clotting of the harvested marrow. Following the heparin rinsing of the syringes, the aspiration needles need to be rinsed or coated with the heparin solution as shown. This is another very important preparation step which should inhibit or reduce the likelihood of clotting during the marrow aspiration. Finally, turn the plunger on the vac lock syringe counterclockwise until it is in line with the internal shelves. This will allow the physician to pull small volumes of bone marrow aspirate. This section will help in identifying the anatomy for selecting the bone marrow aspiration site using the ileum surgical approach. The ileum may be approached posteriorly or anteriorly, with the posterior approach being suggested to minimize aspiration site morbidity. The posterior approach requires palpation to locate the superior aspect of the posterior iliac crest. The anterior approach requires palpation to locate the anterior superior iliac crest. First, prepare the surgical site and provide local anesthesia to the area unless general anesthesia is being utilized. Make a small oblique stab incision, a skin flap, just above the point of entry. This type of incision can easily be closed using a steri-strip or butterfly dressing following bone marrow aspiration. Remember, all marrow contact components must be rinsed with an appropriate concentration of heparin anticoagulant solution, including syringes and needle lumens and stylets, to prevent clotting. After identifying the anatomy and deciding on the needle trajectory, penetration of the ileum with the aspiration needle should be swift to avoid tissue factors coming in contact with the needle lumen and potentially resulting in activation of the clotting cascade. For an anterior or posterior approach, advance the needle by applying pressure simultaneously with back and forth rotation until a reduction in resistance is noticed, indicating entry into the soft marrow space. If there is difficulty in penetrating the ileum, simply tapping the aspiration needle handle with a mallet while holding the distal end of the needle at the point of insertion and at the appropriate angle should result in swift penetration of the ileum cortex. Penetration of the cortex will be noticed by a reduction of resistance as the needle enters the cancellous bone marrow space. For an anterior approach, introduce the needle through the prepared incision site with the initial trajectory of the needle medially in line with the pelvic wing, as gauged by palpation of the inner and outer tables. The trajectory should be aimed slightly posteriorly at the iliac tubercle to enter the medullary canal just beneath it. For a posterior approach, introduce the needle through the prepared incision site with the initial trajectory of the needle, approximately 40 degrees lateral from the sagittal plane and 35 to 40 degrees inferior from the transverse plane. A general rule is to aim at the tip of the greater trochanter. Following penetration of the ileum with the aspiration needle, advance the needle distally into the marrow space 4 to 8 centimeters for the anterior or posterior approach depending upon the volume of the ileum. Remove the stylet and attach a heparin-rinsed 20 milliliter syringe. Pull a small aspiration of 5 milliliters of marrow. Please note that short, quick aspirations of small volumes results in a greater recovery of nucleated cells than a long pull of a greater volume, which may result in dilution of the marrow with peripheral blood. If marrow does not aspirate easily, reposition the needle slightly. If marrow still does not aspirate easily, remove the syringe from the needle, remove the needle from the incision, and exchange the needle and stylet with a freshly heparin-rinsed needle and stylet. Reinsert the new needle into the incision site and penetrate the ileum approximately 1 to 2 centimeters from the original puncture site as we described earlier. If the first 5 ml of marrow is easily aspirated, the aspiration needle should then be rotated approximately 90 degrees, followed by another small aspiration of approximately 5 ml of marrow, so that a total of 10 ml of marrow is now in the syringe, followed by retreating from the marrow space approximately 2 centimeters, and another small aspiration of approximately 5 milliliters of marrow is achieved. These steps are repeated so that a total of 30 ml of marrow is collected in the syringe. Care must be exercised to assure that the needle tip and side holes remain within the marrow space. If the needle tip and/or side hole or holes exit the marrow space, the needle must be exchanged with a freshly heparin-rinsed needle and stylet in order to prevent the likelihood of clotting of the harvested marrow. Remove the filled syringe containing 30 milliliters of marrow and immediately place it into the blood bag containing ACDA solution. Agitate or rock the bag so that the marrow is thoroughly anticoagulated. It is recommended to maintain the blood bag in motion as each volume of aspirate is added to the blood bag. Reinsert the stylet and advance the needle at a new trajectory along the same plane as the original insertion. The previous steps should be repeated, assuring that the needle tip and side holes remain in the marrow space. If the needle tip and/or side holes exit the marrow space, the needle must be exchanged with a freshly heparin-rinsed needle and stylet, followed by re-entry into the marrow space as described previously. Reinsertion of a freshly heparin-rinsed stylet addresses two important aspiration issues. First, the stylet will prevent the possibility of the needle from bending or kinking. And second, advancing the needle with a distal hole and stylet in place will prevent coring of the marrow and possible blockage of the distal and/or side holes of the aspiration needle. This last issue could also result in the activation of the clotting cascade and therefore can be prevented by following this recommendation. The previous steps should be repeated so that no more than 60 milliliters of marrow is harvested from a single puncture site. Again, the previous steps should be repeated with a freshly heparin-rinsed needle and stylet and a new penetration into the ileum made approximately 2 centimeters from the original puncture site, or the opposite ileum can be used if another 60 milliliters of marrow is required in 5 ml aliquots. Following bone marrow aspiration, Place the marrow into the filter bag by attaching the filled syringe to the in-port connector on the filter bag. Inject the marrow into the filter bag containing ACD anticoagulant. Next, re-rinse the aspiration syringe with heparin solution as shown. And gently mix the marrow with the ACD. Continue to place aspirated marrow into the filter bag until the desired volume of marrow has been collected. If the aspiration needle is removed from the bone space and will be used to make a new entry, it must be re-rinsed with heparin solution so that any tissue or clotting factors are removed prior to making a new puncture. Re-rinse the aspiration needle as shown. Also, remove any dried blood and clotting factors on the surface of the needle by dampening a surgical sponge with the heparin solution and wiping the external surface of the needle as shown. Reassemble the sharp stylet and trocar so that it's ready for the next puncture. Once all the marrow has been harvested, the marrow filter bag should be inspected for signs of any clotting or bone spicules. Signs of excessive clotting may result in a poor recovery of nucleated cells. If seen, additional clot-free marrow should be harvested by closely following these collection guidelines. Next, open the slide clamp on the filter bag and then prime the filter by gently squeezing the filter chamber while holding the filter bag as shown. Attach a 60 milliliter transfer syringe to the outport of the filter. Then, while holding the filter bag above the filter, withdraw marrow by filling the syringe to the 60 ml mark. Once the 60 ml syringe is filled, disconnect it from the filter bag and attach a blunt fill needle to the male lure of the syringe. Remove the processing disposable from the packaging and place it on an appropriate workspace. Following aseptic technique, prep the red access site as shown, and slowly dispense 60 milliliters of bone marrow aspirate into the marrow chamber of the processing disposable through this red access site. The filled processing disposable or disposables are then placed into the Harvest Smart Prep centrifuge for processing the bone marrow aspirate into bone marrow concentrate. Ensure the white access site is aligned with the white dot on the rotor. Also ensure centrifuge balance by placing another filled PD or counterweight balance in the other trunnion. Close the lid and press the start button. Total processing time is approximately 14 minutes. The Harvest Smart Prep centrifuge system can process 30 or 60 milliliters of bone marrow aspirate within a 15-minute automatic cycle. The end result is a 4 or 10 milliliter BMAC product. The next steps involve the removal of the cell-free plasma, followed by the resuspension of the nucleated and platelet cells in a 10 milliliter volume of plasma. Resuspension volumes can be adjusted to accommodate the clinical use requirements. Typical concentrations result in a 4 to 6 times baseline nucleated cell count and a volume reduction of marrow from 60 milliliters to about 10 milliliters. You can see in this image that packed red blood cells remained in the blood chamber, and the buffy coat containing 70% of the nucleated cells has been transferred over into the stem cell chamber. When the centrifuge cycle is complete, remove the PD from the centrifuge and place it on an appropriate workspace. Again, following aseptic technique, prep the white access site. The plasma volume used for cell resuspension is based on user discretion. The syringe with blunt cannula and yellow spacers is used to withdraw excess plasma from the plasma chamber by drawing up plasma until bubbles are observed in the syringe. Using both spacers will leave approximately 10 milliliters in the plasma chamber while removing one spacer will leave approximately 7 milliliters. Remove the syringe and re-prep the white access site. To resuspend the bone marrow cells into the remaining plasma, withdraw the remaining plasma into the 20 milliliter BMAC syringe with blunt cannula and no spacer, and gently inject back and forth into the plasma chamber. Repeat these steps 2 to 3 times until cells are visibly resuspended in the plasma, and withdraw total volume into the syringe. Observe the base of the plasma chamber to confirm that all cells have been withdrawn into the BMAC syringe. The BMAC is now ready for use.